My talk today is entitled Advanced Nutrient Therapies for Bipolar Disorder. We're the Walsh Research Institute. We're a not-for-profit public charity based in Naperville, Illinois. Our expertise is in schizophrenia, depression, anxiety, bipolar disorder, ADHD, autism, behavior disorders, and one of our main roles is experimental research, which has been part of our activity from the very beginning. We have a lot of clinical experience. In fact, I think I have the world's biggest databases, chemical databases for several of these conditions. We've worked directly with and done lab work on more than 10,000 people diagnosed with behavior and ADHD, 3,500 schizophrenias, 3,200 people diagnosed with clinical depression, and 1,500 cases of bipolar disorder. We have hundreds of thousands of blood and urine chemistry results. There are striking chemistry differences between mental illness populations and the rest of society, and it certainly goes for bipolar. We find that there is a limited number, just a few chemical factors, or you might call them nutrient factors or biochemical factors, that dominate the imbalances that we see in bipolar. These are overmethylation, undermethylation, zinc deficiency. You see a lot of copper overload in bipolar, folate deficiency, or folate overload. Folate and methyl are two factors that are extraordinarily important in activity at serotonin, dopamine, norepinephrine receptors. Pyrrole disorder, which is an inborn genetic disorder that results in extremely low B6 and zinc levels, and then heavy metal overload. And then there are those who have fatty acid abnormality. Looking at our data, bipolar disorder is an umbrella term used for different mental disorders, and we believe each one of these requires a different treatment approach. It appears to us that the four phenotypes of bipolar are undermethylation, overmethylation, copper-zinc imbalances, and severe oxidative stress. The undermethylation and overmethylation have a lot to do with serotonin and dopamine neurotransmission. Copper and zinc have a lot to do with norepinephrine and dopamine, which are implicated and the subject of a lot of research for bipolar. Severe oxidative stress has been seen in most cases of bipolar, and we know it has a really deleterious effect on the NMDA receptor, which is now known to be very important also in mental health. We have individualized nutrient therapy. It's a medical process. It needs a physician that knows what he's doing. Medical history and review of symptoms. You really need to know everything you can about this patient. And one reason this is really important is that every one of these bipolar phenotypes has completely different symptoms associated with them. For example, one group is prone to seasonal allergies. Another group is prone to chemical sensitivities. We've now collected dozens of symptoms and traits associated with each of these biotypes. And then special blood and urine lab tests, $300 or $400 of lab testing. We can pretty efficiently identify which biotype a patient has. And then diagnosis of chemical imbalances. And then, of course, we then have an individualized nutrient program aimed at normalizing brain chemistries. Now, we've done open-label studies. We don't yet have double-blind controlled studies. I have applied repeatedly for funding for double-blind controlled studies because that's the best way to decisively determine the outcomes or the efficacy of a treatment. But to this point, we have open-label studies, and 74% of our patients report treatment effectiveness and the ability to reduce or eliminate medication. And usually it's a reduction of medication, not an elimination. Our treatment works in harmony with psychiatric medications. Today, most of the patients we see diagnosed with bipolar have 3 or 4 heavy-duty psychiatric medications at the same time. And if we have success, our process is we use both treatments together. We insist the patients stay on their psychiatric medication for several months. And then if we're successful, and if the patient clearly becomes quite a bit better, we have them go back to their psychiatrist and then cautiously try lower and lower levels, determine where they're at their best. And in case of severe bipolar, usually the medication levels can be reduced to a very low level, very often eliminating whatever side effects might have been a problem. We are not trying to eliminate medications. Our goal is for the patient to be at their very best.